We are moving on to our next speaker, Dr. Abraham Chachoua, who is the J. and Isabel Fine Associate Professor of Oncology in the Department of Medicine, Hematology and Oncology here at Perlmutter Cancer Center, and he's going to speak to us today about medical treatments for lung cancer. Let's welcome Dr. Chachoua.
So always tough to follow after Harvey and Larry, but I will give it a shot. I'm sorry about my slides. I'm not very good at making slides, so try to make my own. So I thought this year, instead of giving you a lot of background, I would focus on what folks ask me the most when they walk in to see me, okay? Unfortunately, I see the majority of the patients I see was after the cancer had progressed, and I get asked about treatment options. And this past year has been actually a really good year in terms of newer things, newer weapons we have to offer patients. So not so much background, but I'm going to tell you a little bit about what people ask me about. People ask me about these two things more often than anything else: immunotherapy and targeted therapy. Okay, so we're going to spend a little bit of time talking about those. All right, so immunotherapy. So, for many, many years, the concept of stimulating your immune system to kill the cancer has been an approach. And in fact, when I was much younger, one of my very first studies 20 years ago in lung cancer was to look at giving immunotherapy drugs to stimulate the immune system. So the concept that we had is that your immune system, if you have cancer, this is back then, your immune system is not very good. And if you beat it up with stimulants, you will stimulate enough to kill the cancer. Okay, so that strategy did not work, all right? But it is still an attractive thought. It should make sense that your immune system can kill the cancer. So why doesn't it work? Because what we used to think is that lung cancers were not immunogenic. Your immune system is deficient. You can't kill cancer because you can't recognize it. Now, this all changed with the advent of the checkpoint inhibitors. So PD-1, PD-L1. Okay, so what we understand now is that your immune system actually is not so bad. It just has a blind spot when it comes to cancer, okay? Why? Because the cancer is clever, and it makes on its surface and on the surface of the immune cells these immune checkpoints that when your immune system comes in and to try and kill the cancer, it gets turned off, all right? So it has this one very specific blind spot where it turns it off, and then after a while your immune system gets tired and says, I don't want to do this anymore, right? So that is actually the major thinking behind the current era of immunotherapy. Okay, so what we know now is that immunotherapy can cause significant shrinkage in lung cancer in about 20% of patients with non-small cell lung cancer. And also, there is now more recent benefit in small cell lung cancer. In many years, when I would talk here, I would have nothing to say about small cell, but that is also changing with immunotherapy. Now, you can get clinical benefit, however, in up to 50% of patients from immunotherapy. And now we have 3 drugs that are approved in non-small cell lung cancer. And most significantly, 1 drug is actually approved in the frontline setting, okay? So let me tell you a little bit about the story. The concept behind immunotherapy now is that you give the patient an antibody to PD-1 or PD-L1. This is given intravenously. And what this antibody does, it goes and blocks the PD-1. So it blocks the blocker of your immune response, okay? And that way then your immune system says, aha, I see the cancer, I'm going to go kill it, all right? Now, so there are 3 drugs out there. And to tell you the story, the first drug that actually was approved is Opdivo. And you turn on your TV now, you see all these Opdivo ads with the doctor with the iPad saying Opdivo, Opdivo, right? So that was the first drug that was approved. And the second drug that was approved was pretty much about the same time, was Keytruda or Pembro. And then the most recent one is called Tecentriq or Atezo, and that's made by Genentech, right? So you have three companies, have three products, and each of them have gone through the same kind of process. Each of those drugs is approved for what's called second line. You get chemotherapy first, you get immunotherapy second, okay? And it was approved based on very similar trials. Immunotherapy drug versus chemotherapy drug, right? And the chemotherapy drug in each of those three trials was actually Taxotere. So immunotherapy versus Taxotere in the second line setting, immunotherapy is superior. Okay. Now, the nuances, however, is what makes the story, right? So when Opdivo was developed, everybody with non-small cell lung cancer was enrolled on these trials, okay? And everybody had their tumor analyzed for whether they have PD-1 receptor or not, right? Because the one thing that you want to ask is, can you predict who is the patient that immunotherapy is going to help? And to be true, we don't quite know that yet, but one of the things that people thought about is, well, if this drug I'm giving you is going to hit PD-1, then if you don't have PD-1, then it's not going to work, right? So what if I measure PD-1 and use that as my surrogate endpoint, right? So the Opdivo folks, they measured it, but it was not a requirement for study entry. And so in that trial, then Opdivo was superior to chemotherapy, single agent chemotherapy with Taxotere, and that's what led to the approval of that drug, right? Pembro, or Keytruda, they actually looked at PD-1 levels and selected only patients with very high expression. Greater than 50% of the tumor cells had PD-1. So they selected a group of patients that was more likely to benefit. And so when they compared Keytruda with chemotherapy, it was also beneficial, but the numbers are a little bit different from Opdivo. The numbers are higher for Keytruda than it is for Opdivo. So the question is Pembro a better drug than Nivo, or is it selection of patients? And each one of those pharmaceutical companies have developed their own test kit for PD-1 expression. So you can't actually compare, all right? So the third drug, which is the most recent approval, is Tecentriq, and that's a PD-L1 inhibitor, and that was also along the Opdivo model. The PD testing was not a requirement for those trials, okay? So which one do you choose, right? So which one do you choose depends, because the next big thing, which was the approval from 2 weeks ago, is the approval of Pembro or Keytruda in patients who've never had chemotherapy. Okay, so this is now the big deal, right? So what happens is when you have a drug that works in the second line setting, you ask yourself, well, it is going to work in the first line setting. Okay, so again, similar to what I said before, Opdivo or Nivo was compared to chemotherapy, this time with 2 chemo drugs, in people with non-small cell lung cancer who've never had treatment. And in that setting, chemotherapy was better. So that is what led to the Bristol-Myers stock going down, okay? But by the same token, same trial of Pembro against chemotherapy, 2 drugs in people who've never had treated, selected by the expression of PDL, high expression, Pembro was better than chemotherapy. So now the landscape is changed, right? The landscape now is when you ever have a patient with non-small cell lung cancer, first diagnosis, you now have to, if you want to do a decent job, you want to now have to check for the PDL expression. Because if you have high PDL expression, then you know that that person would benefit from getting immunotherapy first, okay? If your expression of PDL is low, then giving chemotherapy first may make more sense, all right? So that's an important point, because now, you know, as medical oncologists, we depend on surgery, we depend on interventional radiologists to get us more tissue. And so tissue is even more important now than what it used to be, you know, even last year. Okay, so immunotherapy, however, is not without problems, okay? First is it doesn't really work for everyone. Even if you have a high PDL expression, it doesn't always work, right? So maybe there are other factors that we don't understand, and people have began to look at that. Is it the number of mutations? Is it the whatever? So there is a lot of effort now to try and refine who immunotherapy works for. But there are a lot of side effects. Okay, so it's different than chemotherapy. And I would have to say that it's probably milder than chemotherapy, but there are side effects. If you turn on the immune system too much, you can develop autoimmune disease. Your immune system becomes indiscriminate at attacking parts of your body that, you know, are normal. So the commonest actually is fatigue and nausea, okay? But there is everything that ends with itis can happen with immunotherapy. Dermatitis, skin rash, diarrhea, colitis, hepatitis, lung inflammation, pneumonitis. So in general, about 20% of patients get these toxicities, but they can be very serious. And then they would require you to give high doses steroids for a while. And some of those toxicities would say then you cannot give immunotherapy anymore, even if it's working, right? Now, interestingly, also, a lot of these side effects, a lot of these toxins can last for a long time after you discontinue immunotherapy, okay? So thyroid problems, thyroiditis can last indefinitely. I have a patient who was actually treated with immunotherapy and stopped, had a complete response, but had to stop the drug because of colitis, diarrhea, about now almost 2 years ago. He was in the trial. He still gets intermittent attacks of colitis, okay? Now, you know, he doesn't have cancer anymore, okay, but his quality of life is not the best because of this. So just you gotta balance out all these factors in your decision making, but certainly it is one of the biggest advances in lung cancer treatment. I should say that patients with autoimmune disease were not enrolled in any immunotherapy trials because of that factor. And so, you know, recently I had a patient who had ulcerative colitis that had failed chemotherapy, and there was a big dilemma. Should I give that person immunotherapy, take the risk of the colitis to get worse or not? So that's immunotherapy. Now, who benefits from immunotherapy? Interestingly enough, smokers. Okay, I'm not saying you should go out smoking, but in contrast to the next part of the talk, which is targeted therapy, which is really focused on never smokers, smokers benefit from immunotherapy more. Why is that? Well, so the interesting part is the evolution of thinking about cancer. Now people talk about hot cancers and cold cancers. Hot cancers mean cancers that have a lot of inflammation in their medium. And so your immune system is kind of right there. And so smokers tend to have hot cancers. The folks that have never smoked and have one mutation, they tend to have cold cancers. So immunotherapy works better in smokers than in never smokers. So folks have had, I mentioned high PD-L1 as being a surrogate marker for immunotherapy working, but also some other folks have looked at what's called high mutation burden. The tumors that have lots of different mutations, these are also more likely to respond to immunotherapy. So, you know, nowadays there are some companies that can actually come back with a mutation score of your cancer and see if you're a candidate for immunotherapy or not. Okay, so then to wrap up immunotherapy, the anti-PD-1s have durable benefit and have toxicity, not as bad as chemotherapy in many patients. It also has some activity in small cell, as I said, and maybe in mesothelioma and maybe in thymoma, okay? Thymoma is a cancer of the thymus gland, although that's a bit of a more complicated story. The PD expression may predict benefit And importantly, PD expression can change over time. So if you start off being PD-1 negative, it doesn't mean that you're going to stay PD-1 negative, because things can upregulate PD-1 like chemotherapy, radiation therapy. So it's worthwhile, if you remember, all these studies were done on archived tissue, So now there's a whole point about getting more tissue as you go along to try and measure these things prospectively. Okay, now, so far, we've talked about single agent immunotherapy, Opdivo, Nivo, Pembro, Tecentriq. How can you improve the success rate of immunotherapy? And that's now going to be the next 5 to 10 years, right? So every few years you get like a breakthrough, and then the next 5 to 10 years is you're going to try and fine-tune the treatment. So right now, then, there is, copying from the melanoma setting, there is an effort to try and do combination immunotherapy. Okay, so there is actually a second drug out there that's a checkpoint that's approved in melanoma called Yervoy or ipilimumab. And so combining one of these PD-1s with with Yervoy or ipilimumab, we think is actually better than single agent, but certainly more toxic. And in small cell particularly, the data presented at ASCO showed that combination of those two drugs is better in small cell than single agent. So we're going to see a lot of combination trials coming down the road of new checkpoint inhibitors. We're going to see combinations of chemotherapy plus immunotherapy. Now, does that make sense? I'm a basic guy, so I kind of never thought that giving chemotherapy, which can suppress your immune system, combined with immunotherapy, which stimulates your immune system, works. But the immunologists tell me, Dr. Chachoua, you don't know anything. Chemotherapy, which is true, chemotherapy actually can be an immune stimulant because you kill cells and you expose them better to your immune response, right? So we wait and see whether these combination trials are going to pan out. And then also radiation plus immunotherapy, that's also another approach that people are looking at. So the next 5 to 10 years, combination of newer checkpoint inhibitors, combinations with other modalities. And then also bringing immunotherapy earlier on in the course. So, for example, giving it adjuvantly after surgery or giving it just before surgery. So there's going to be a lot of that stuff happening over the next years. Okay, but let's not forget that targeted therapy is still a big deal. So targeted therapy, basically, again, you can now take a sample of tissue, you can analyze the tissue and see if there's a driver mutation. So nowadays, we do that routinely. There are about 5 or 6 driver mutations. These are the mutations that lead to the cancer growth. And if you can block those driver mutations, you can get lots of benefit. So the first one that was described was EGFR, and the EGFR mutation. So nowadays, going from one drug, we have 3 drugs that are approved for use in EGFR mutation positive lung cancer in the first line setting, so before chemotherapy. There is a 4th drug that's approved for use in resistance. So what happens with EGFR is you target the cancer with this pill, and then after a while, the cancer learns how to counteract this pill, right? And so how do you fight that? You fight that by getting a fresh biopsy, or now even a liquid biopsy, which we can discuss later, where you can analyze and see what the mechanisms of resistance might be and see if you can target those, right? So that's the approval of the drug called Tagrisso over the past year or so. There's been a lot of excitement about ALK. About 5% of patients with lung cancer have this ALK fusion, which is make it susceptible to treatment. And so the excitement has been several. There are now 3 approved drugs, but in our general meetings last year, this year, is it this year? Yeah, this year. One of the drugs, alectinib, was actually showed in a big trial that may have been superior to crizotinib in people who've never had treatment before. So that's, with biotechnology developing better drugs, maybe we have a better choice for frontline. And now there's a whole slew of second-line ALK inhibitors out there. So I think that, targeted therapy is a small subset of patients, but they benefit greatly from targeted drugs, and there's lots of new drugs that are targeted now. So I think the message, is always get tissue, always analyze what the cancer is susceptible to, and then design your treatment strategy based on that. So this is what people call about personalized medicine, personalized oncology. Lots of new drugs this year compared to every year I've stood in front of you. So I'm hoping that next year, if I'm still here, I can describe to you more advances of treatment in lung cancer. So I leave you with a message of great hope, because now we have many weapons. It's just a question of how to combine things together. Okay, so that's my talk.